So our next speaker is well known to many of you, and this is Chris Barnes, haematologist extraordinaire from the Children's Hospital.
So I see some familiar faces in the audience. I'm a haematologist at the Children's, and my experience with HHT developed because in part my niche area at the Children's is looking after patients with bleeding disorders, and that's a disorder that largely affects young boys called haemophilia. And those patients and other patients with other bleeding disorders would turn up with blood noses. And so I've developed a bit of an interest in blood noses. But blood noses in HHT are very different, and it's helpful for me to have experience and listen to the patients with hereditary hemorrhagic telangiectasia, because you guys suffer blood noses like no one else. While some patients with haemophilia and von Willebrand's or platelet dysfunction have small degrees of blood noses, patients with HHT they're dramatic and life-threatening, as many of you know. So it's through that portal that I've developed a bit of an interest in HHT, and in part because it's a disorder that, as I'm sure you'll hear today, affects a number of different organs. And as doctors, hopefully we're okay at looking after our one particular area. We're not great at coordinating with other specialists because we'll come in and we tend to be almost too focused, whereas I think it's important in HHT to have a broader view of the disorder, and that's where Ingrid's expertise really becomes very helpful in coordinating all of us to look after patients in that holistic approach rather than just our focused area. But right now I'm just going to look at my focused area, and that's how HHT in my perspective of HHT. So briefly, diagnosis, which is often the first discussion that I have with patients who may be coming with symptoms of HHT, the screening of the complications. And many of you, this audience is a very well-informed audience, so I suspect this will be a revision rather than anything novel. A brief discussion about epistaxis and an area that I do focus a little bit on, and that's the treatment of iron deficiency. So these pictures are familiar to you. These are the vascular lesions which occur on the mucous membranes and on the skin. Might be a bit hard to see, but just right in the corner of that eye is a very classic description of an AVM on the conjunctiva. They obviously occur in the deep organs, including the lungs, which is an area of significant morbidity. And then we have an understanding from at least a cellular and now a molecular level of how HHT occurs and the gene changes associated with them. This is an important graph for me. This helps me direct the appropriate screening tests for patients. The grey area is a broad graph which shows when symptoms start to develop, and you can see really with the percentages on the left-hand axis. And you can see really by the mid-teens, most patients with HHT are developing symptoms, and that's really with epistaxis as being the most common cause, or blood noses. The cerebral AVMs, the CAVMs, or central nervous system AVMs, we think we can pick those up from an early stage, although we should continue to screen for those, or at least once more later on. And then the pulmonary AVMs, the ones that occur in the lungs, which are associated with significant morbidity, they can continue to increase, and there's a bit of an upswing around the sort of adolescent period, and there'll be the need for the continuing screening. So that's sort of a rough template of how we approach patients with HHT in our clinic. So just focusing on the pulmonary AVMs, these are of major significance in that they can cause significant bleeding, and if they're not bleeding, they can cause reasonably significant complications of cerebral abscesses, as well as infections in the brain, as well as reduced exercise tolerance. And they occur ultimately in up to half the number of patients, depending on what gene change is affected. And many you guys, as I said, you guys are a very informed audience, so you'll know all this stuff. not that there's any good news about this, but at least in children we have very sensitive screening techniques, and so that's with a contrast echo, where a little bit of air is shaken up into some normal saline. It's injected into the veins that passes up through into the pulmonary circulation, and if there is no abnormal connection between the right side and the left side of the heart, meaning that there's no pulmonary AVMs, we shouldn't be able to see bubbles on the left side of the heart. It's a very sensitive test. It's relatively harmless. It's a little bit of a challenge in little guys, but it's a very effective test to exclude pulmonary AVMs, and it doesn't involve lots of radiation, and we order a lot of contrast echoes in our paediatric population to exclude the lung issues. If there is evidence of that shunt, what we call a shunt over from the left to the right to the left, then it's important that we do the gold standard, and that's the CT scan. CT scans have radiation associated with them, so that's why we don't like to do them up front if we don't need them. Once we've identified that a child or an adult patient has a pulmonary AVM and a malformation in the lungs, then we bring in the experts, the respiratory doctors, and the interventional radiologists. So that's X-ray doctors who are expert at X-rays, to be able to decide the size and the technique to try and get rid of them. Part of the reason pulmonary AVMs are so important is that the lungs are a very fine filter. They're part of the immune system. And if we have an abnormal connection where the blood can zip right through the lungs instead of going through a very fine filter, there's the potential that some bacteria can go through that circulation and unfortunately result in infections in the brain or cerebral abscesses. So that's why it's really very important that we understand if a patient does or doesn't have pulmonary AVMs. And it's also important that when patients with HHT who haven't been screened have antibiotics around the time of procedures, because when you're having a procedure like a dental procedure, when a tooth gets pulled out, or a minor surgical procedure, you will get a shed of bacteria through your circulation. It's a normal event. But you've got your spleen and your lungs to be able to mop up those small showers of bacteria. Unfortunately, if it zips right through because of that abnormal connection between the artery and the vein in AVM, it can lead to cerebral abscesses. So when you do go to the dentist or have a minor surgical procedure and you think that there's a risk of pulmonary AVM, it's important for you to have prophylactic antibiotics just in case. It's usually only a single dose, and that's been demonstrated to be really very effective at preventing these complications. And it's because the incidence of pulmonary AVMs or these malformations in the lungs can continue to occur and redevelop. It's important that we can offer CT scans on a regular basis. Usually that's in the setting though of having some input by the respiratory, the lung doctors and the X-ray doctors who'll be closely monitoring those malformations. Now, cerebral AVMs, so that's these malformations occurring in the brain, they're less common, which is great news. The unfortunate news, however, is that they are associated with really bad side effects, including bleeding into the brain. And it's for the reason that they're associated with such significant side effects that we treat screening of them really carefully or importantly. And our approach is that we try and get a scan on the brain as soon as practically possible. So I'm using these terms carefully. If it's an infant that we know has got a history of AVM, a history of hereditary hemorrhagic telangiectasia in the family, and there's a genetic diagnosis, we can do CT scans in a newborn very early on. That's when they're asleep. We can do it quickly through a MRI, and they don't need a general anaesthetic. Toddlers obviously are much more of a challenge, and they're going to have to go to sleep for that procedure. So it's a bit of a discussion about what the patterns of cerebral AVMs in the family, whether or not they're present or not, before we make that decision to put a child through the risk of a general anaesthetic. But certainly the older child, typically around 7 or 8, with some play therapy involved, can go through the magnet without a need for a general anaesthetic. So we sort of modify our approach to how we arrange scanning on young children. Clearly, if there's an adult who is newly diagnosed, and I should say that happens, fortunately, I think infrequently, but probably should be happening more often. And that's because HHT is underdiagnosed. Patients go around with blood noses on a regular basis, and it's not until they get into the spotlight of someone like Ingrid or potentially myself that we're able to think outside the square and say, gee, that epistaxis, that blood nose, that's a little bit more severe than we normally see, or we examine the patients and we look for those cutaneous, those skin lesions. We ask about his family history of people having strokes at an early age. And it's, maybe through education like today, where hopefully people can understand that we do miss patients with HHT. They might not have such dramatic blood noses, but patients are out there suffering from HHT without the appropriate diagnosis. An MRI doesn't have any radiation, so an MRI, apart from the need for a general anaesthetic, is a very safe procedure. And fortunately in Melbourne, really we can access MRIs really pretty easily. So it's important that if we can exclude lesions in the brain, that we do that at a very early age. Just briefly, HHT in pregnancy is an area that isn't supported by significant evidence or guidelines. So I should say, as a medical professional, and I think Ingrid would agree with this, our practice should really be supported by international best practice. The evidence around, the research and the evidence around HHT is certainly improving, and it's at a moderately high level, but it's at the level of guideline-based, not truly evidence-based. So we don't have enormous amount of research about the impact of HHT in pregnancy. So we have to be guided a little bit on first principles in this space. And it's in that setting that we have a very collaborative approach with obstetricians, etc., to make sure that if there are any complications in pregnancy, that we're aware of them. But in essence, things can get worse in pregnancy. And in a female patient who has hereditary hemorrhagic telangiectasia, I suppose my advice would be to touch base with the obstetrician and maybe reach out to the local HHT experts about what should be done in that space. Recognising that things get worse, but we shouldn't do any harm. That's a principle in medicine that we try and follow as much as possible. We shouldn't do any harm. So there's a non-enormous amount of evidence about what to do in pregnancy, so that's why that collaborative approach is really very important. Now, I'm just going to touch base on epistaxis. So this is probably far too common for you guys. This is a minor nosebleed, and Joe's an expert, and we're very lucky in Melbourne to have Joe available to us now to be able to refer patients off to, because my experience with ENT surgeons is that they find bleeding a challenge, in particularly nosebleeds. And I think, and I hope I'm not being too critical of ENT surgeons in the past, but I think maybe they haven't thought slightly outside the square with regard to hereditary hemorrhagic telangiectasia, and they've intervened when maybe it might not have been necessary. They sort of at all costs stop the bleeding, which can involve multiple episodes of cauterization leading to perforation, etc. So I don't criticise other doctors because I'm not there in that space, but I think having experts like Joe around to moderate our approach, I think is really very important. And that picture on the right really just demonstrates that it's a very vascular procedure, a very vascular area, and that's part of the reason why HHT is manifests as blood noses in this space. This is a list. This is not particularly up to date, but this is I don't need to know the detail, but the list of the number of studies that have looked at trying to sort out blood noses in HHT. And whenever there's a whole lot of studies doing very different things, it tells me we haven't got the right answer. And I still don't think we're really on top of what to do with hereditary hemorrhagic telangiectasia and nosebleeds. So it's in that space, I think, having professionals like Joe and being a little bit more collaborative and maybe a little bit more careful with how we manage nosebleeds, I think is important, because I don't think we've nailed this completely. Just in terms, someone asked before, how do you know how much is bad or good with regard to nosebleeds? There is a epistaxis severity score, it's freely available. And in medicine, we do like to quantitate things as much as possible. If not to help us in the clinic room, it can, with regard to diagnosis, it can be helpful to monitor patients. And if you look up epistaxis severity score and throw in, it's still subjective, you know, by its very nature, it's still very subjective. But having an understanding of what your severity score is helps us in the clinic to decide, has it got worse or has it got better in an objective way. So that's something that's worthwhile, I suppose, taking away, recognising that it's in an inexact science. The result of epistaxis is iron deficiency. So on the left-hand side is a blood film, and you can see the red cells, there's a white cell in the middle, but those red cells have got a nice healthy rim of hemoglobin in them, whereas these cells here are very hypochromic. They're still being produced, but they don't have any iron in them. And that's a classic feature of patients with significant nosebleeds leading to iron deficiency anemia. And we can pick that up in the laboratory relatively easily. Iron deficiency is very common, so I was just going to spend a couple of minutes on iron deficiency. So we have about up to 5 grams of iron in us at any one stage. Iron's it's important for blood, but it's also important for intracellular processing of enzymatic activity. It has a broad, far-reaching impact, right down to, some people can relate to the concept of pica or cravings in pregnancy. We think cravings in pregnancy and pica, which is what happens in kids, are very low in iron. They start to eat sand or ice. That has a central nervous system effect, and that's because of the impact that iron has on the non-blood parts of the body. It's a very important element. We hoard iron as organisms. We've developed over 40,000 years where iron hasn't been that freely available in the environment, and so when we've been able to get it through eating a mammoth or something, we've hung on to it. We don't get rid of lots of iron apart from bleeding. So in non-HHT patients, that's females with menorrhagia or heavy periods, and in HHT, that's patients with blood noses. And it really is a very dramatic impact on the body when you lose iron and develop iron deficiency over a long period. In terms of being able to maintain adequate iron, what we call homeostasis or balance, it's really largely it's meat, it's animal products. Animal products or meat contains a form of iron that is called heme iron, which is really readily absorbed. It's absorbed in there. It isn't impacted on other parts in the other substances in the gastrointestinal tract, whereas the non-heme on the other side, that's the green leafy vegetables, etc., is much harder to absorb. You can still get it. You can still definitely get it. I'm not saying patients, for instance, who are vegetarian need to eat meat, but you tend to have to eat a lot of those non-heme sources to maintain normal iron stores. So that's normal iron stores, let alone patients who, in hereditary hemorrhagic telangiectasia, are having regular nosebleeds. The way we measure iron, it's really simple. It's a blood test. We can't really predict if someone does or doesn't have iron deficiency we can predict if someone is anemic, and that's because of the pallor. So if you remember, iron goes into the gut, gets absorbed to the bone marrow produces the red cells. Iron deficiency happens in a staged procedure, so the first thing that happens is that the iron going to the bone marrow is reduced, and so we call that pre-latent iron deficiency. And then if that continues, the patients will drop their red cells and become iron deficient. They'll develop iron deficiency anemia. So the ferritin level, if you have HHT and you having blood noses, you really should have an understanding of where your ferritin level is, not your iron level. A serum iron goes up and down on a day-to-day basis. The ferritin is the best measure of long-term iron stores. And anyone who is having blood noses, anyone's having blood loss, so I include girls having heavy periods, your ferritin should have a 5 in front of it, 50 something. The normal range is probably about 10 to 200. So it should be at least in this area. If it's down in this space, you don't have a lot of flexibility, a lot of room to move. So a ferritin with a 5 in front of it is generally what we try and maintain in patients who are having bleeding symptoms.
Is it just a normal blood test?
Normal blood test.
So if you're looking for something else, what do you ask for from the doctor when I'm about to do a blood test?
Yeah, so when you get a blood test, there's a couple of standard tubes that are taken, and those standard tubes depend on what is being tested for. But your standard blood test is your blood count, so that's the hemoglobin, the red cells, white cells and platelets, and that goes in it's usually a purple top tube. And then there's another series of tubes which we want to test on the serum. So we get rid of all the cells, and we check the serum, and that's the iron studies. So iron studies is the complete test of iron profile, but out of all of those, the only one we want is the ferritin. That's the only one that's really important in this space. And then out of that serum, you can check your liver function and kidney function and all those parts. But if you're getting a blood count and you only get one tube taken, ask for another tube, if you know what I mean, so that you do in fact get iron studies. The management of iron deficiency, you would think it'd be pretty straightforward, but and I don't want to overthink this, and maybe to put a little bit of make a little bit of a comedy out of it, but this is a bottle of iron therapy, and there's two elements that I want you to focus on. One is that it's still full, and that's because the patients aren't compliant with it because it's doesn't taste great. This happens to be for a paediatric patient, and the other is that the label's been ripped off because the kid's eaten it because he's still got pica. So that just demonstrates to me that iron deficiency treatment is a challenge. Abdominal discomfort happens when you're on therapeutic doses of iron, so when you're on the right dose of iron. Tummy discomfort or constipation or reflux can happen in maybe 40% of people, which is if there was a medication out there that had a side effect of 40%, 4 out of 10, it might not actually, get up anymore, if you know what I mean, because it's oral iron can be toxic. And there's a whole lot of different forms of element of iron, and some people say, well, I'm on this iron and I don't have any side effects, which is great, and that might be the 60%. But then I ask patients what sort of iron it is, and if they're not getting side effects, often it's because they're not getting any iron in some of the over-the-counter preparations. So it's important that when you have iron management for iron deficiency, you are on the right dose to replenish your iron stores, on the understanding that it can be associated with side effects. At the top that says intravenous iron, so that's iron into the veins. If we can't get it in a patient orally, or indeed we can't get enough in orally, we use iron intravenously. And over this part of the graph were the older iron, and they were the older forms of iron, and they were associated with lots of side effects. The main side effect was almost like an allergic reaction to the carrier of iron. So iron needs to be dissolved. Iron's a metal, and it needs to be dissolved in a sterile solution so that it can be injected. And there was difficulty finding something that was inert enough that patients didn't react to. And we've fortunately found one with ferric carboxy maltose, or Ferinject, which has been available for about 4 years now, and it's changing the way we manage iron because patients aren't reacting to that carrier, and it's making a big difference in this space. Ferinject can be given quickly in the rooms. There's a low allergic rate. I think I put the side effects. Yeah, there's still side effects to iron, however. That's not a very good graph, but a very good picture, but that relates to the last of the side effects, and that's a tattoo. If iron doesn't go straight into the veins and goes into the tissues, it causes a tattoo, which is permanent unless treated, and the treatment is via laser, and it's complicated. So we want to make sure that that side effect is minimised as much as possible. But intravenous iron in general can be used for patients who have got increased demand, such as patients who have hereditary hemorrhagic telangiectasia, or if there's poor compliance due to GI symptoms. So the reaction rate, it still happens, particularly the serum sickness-like illness, which is feeling a bit fluey a day or two after an iron infusion, is still relatively common, 1 in 40, but it's self-limiting, and we can work around it if needed. But it's still not ideal, but much better than it used to be. So that's all I really wanted to say about haematology. As I said, I have got an interest in HHT because of the association with some of the bleeding symptoms. And it's fortunate that we've got someone like Ingrid in Melbourne sort of coordinating all of us to try and manage this disorder that has multi-system involvement. I'm very happy to answer any questions or be contacted afterwards about the haematological management of it. And thanks for the chance to present this morning. Thanks. So tranexamic acid is what we call an antifibrinolytic. So what it does is it stops clots dissolving. It doesn't promote clots, it stops clots dissolving. So particularly relevant here, when you've got a leakage in a blood vessel and blood's pouring out, your body will come along with the plasma proteins and the platelets to try and seal it up. As a normal physiological process, then other enzymes come along to dissolve that clot, which is normal. They try to modify it so that begins the body healing. So antifibrinolysis stops that second process, and so it makes clots stronger and hang around for a bit longer, which is really what you want, up your nose. But clearly, if you're making clots stronger and stopping the clot dissolving process, the downside to that is the potential for clots to develop or to continue in areas where you don't want them. And the major one, at least with tranexamic acid, to be honest, is in the heart. Because we're all getting a bit older and all our coronary vessels probably aren't as good as they can be, with areas of relative blockage, we call them stenoses, relative blockage. Tranexamic acid could facilitate a clot happening in that space. So generally, we don't recommend tranexamic acid for long periods of time or in the elderly population where the incidence of coronary heart disease is common. Now, having said that, there's risks to everything we do and don't do. If tranexamic acid is avoiding the need for recurrent blood transfusions or iron transfusions, and there's a small risk of increased clot, you'd sort of weigh up the balance. But just to make it clear, in clinical medicine, nothing is risk-free. Doing nothing has associated risks. So that's why in the discussion with tranexamic acid, we talk about the risks and benefits. If you had a very strong family history of heart disease, you're a smoker, etc., it might be that we'd use tranexamic acid for only short periods of time, for instance. But I feel comfortable prescribing it on the basis that you can discuss that with the patients.
So I've heard in a few different accounts that the transition from the children's system to the adult system can be quite a hard one, and that from someone who's looked after kids with this and been involved in sort of the diagnosis and monitoring, I'd love to hear your perspective on what could be really done better in terms of that transition from children to adult system?
Yeah, so just very brief comments, that the hospitals are funded to look after patients according to age. So the Children's Hospital has funding to look after patients. The definition varies a little bit depending on who you speak to, but 16 and above is probably not considered paediatric. We extend that out to high school, the end of high school. The reason for mentioning the funding is that there is a genuine push from the hospital executives that once they are outside of that age group to transition them. So we don't have any option to continue to look after patients. In fact, if there was a patient who was 19 or 20 coming into the outpatients department, they'll be quickly on the phone and saying, what's going on? It's not because they're mean, it's because they're not funded to look after patients. So that's the first principle, that transition is here to stay. I think the issue with transition is that we don't prepare kids well enough. And that's almost, I could go into this for hours, but that's almost a societal aspect. So as a child, you generally are within a family and have stakeholders, meaning your parents, well and truly beyond that 18 years of age. There aren't many kids these days who leave home at 18 and aren't in their parents' control. Is that a fair statement? And yet in adult healthcare, you go to an adult healthcare, I suspect it's different with Ingrid's unit, but you go to adult healthcare, they don't want to talk to the parents. It's the child. In fact, their mandate is that the parents are excluded from all of decision making. You're actually talking to an adult now. But we're not really adults until we're sort of in our mid-20s, really, these days. So it's in that framework the transition is complicated. So what we should do at the paediatric setting is prepare kids a little bit earlier to be a little bit more in control. And I think the adult healthcare services probably have to wind back there. We're not going to talk to the parents, we're now dealing with the adult, because that's almost a perfect disaster to happen. You know, a kid walks into a clinic room, someone who's is a little bit on their high horse will say, well, you're out, the parent, and the kid's left there completely unprepared by us. And that's where transition can go badly. What can work well is when you have people talking to each other. Surprise, surprise. When I can ring up Ingrid and say, someone's coming over, I'm going to refer you to Ingrid, and Ingrid knows about HHT and it works very well. Or in other disorders, I look after patients that go to the Alfred Hospital, and we've got a relatively seamless transition period. But transition from paediatrics to adults is challenging, is definitely challenging. And then maybe the last comment is, you know, as parents, if you've passed on this gene to your child, you are still invested in that from a psychological level, correct? I think that's fair to say. And so to all of a sudden be excluded from care when they hit 18 is just, I actually think that's insane. And yet you go to the adult centres and say, no, we're not, the parents are out here. Parents can wait in the waiting room. We're dealing with this naive 18-year-old. That can be a challenge. That's where it all goes wrong.
I think those are very valid points, and it's compounded by the fact that we've really got two great children's facilities here in Parkville and at Monash,
Yes.
but there are hundreds of options for adults. And you generally go to the one closest to your home, which may not be the one that's kind of well versed.
Yeah, no, that's a very important point.
So while we're having a day of education for people who actually want to know, we need to be educating the people who don't know what they don't know.
Very true.
Other questions for Chris?
Chris, do you know of any haematologists that work out at the Monash Children's Hospital that have a bit of the knowledge of HHT?
Yeah, so
My son's been diagnosed as 9.5.
Yeah.
And so I live an hour and 15 minutes from the city, so it's closer in some respects to go to the Monash.
Absolutely. Yeah, yes, I do. I can give you his details, but RK, or send an email to us. RK is terrific. RK, we call him RK because I can't pronounce his surname. Not that I'm the font of all knowledge, but if there's any queries he has about HHT, we talk to each other on a regular basis.
Thank you very much,
Thanks,
Chris.
Ingrid. Very nice.
So
Thanks for the
thank
chance
you.
of coming.